Nail anatomy. The nail functions by protecting the digits and contributing to tactile sensation. Understanding nail anatomy is not only essential for understanding physiology, but also comprehending the pathophysiology behind many nail presentations. Clinically, many cutaneous and systemic diseases can manifest on the nails. While a thorough history and physical can often correlate nail findings with their etiology, a biopsy may be necessary to reach a final diagnosis. Understanding the anatomy is important when obtaining tissue samples, since an injury to the vital blood vessels and nerves supplying the nail can cause complications. Here we review all significant aspects of nail anatomy and address the clinical considerations. Structure and function. The nail has many soft tissue structures that help support and form the hard outer nail, known as the nail plate. The attached figure depicts the gross structures described below. Nail folds. The nail folds are soft tissue structures that protect the lateral and proximal edges of the nail plate. The proximal nail fold protects most of the nail matrix from trauma and ultraviolet rays. The mantle. The mantle is the skin covering the matrix and base of the nail plate. The cuticle. The cuticle, also known as the Hyponychium, grows from the proximal nail bed and adheres to the nail plate. Together, the proximal nail fold and cuticle form a protective seal against any irritants that may disrupt the nail matrix underneath. Nail matrix. The nail matrix is located deep to the proximal nail fold in the nail plate. The proximal nail matrix begins about halfway between the distal interphalangeal joint and the proximal nail fold. The distal nail matrix is visible through the nail plate as a white half-moon structure called the lunula. The nail matrix is responsible for the formation of the hard nail plate and is the only part of the nail unit that contains melanocytes. The nail cells, termed onychocytes, are pushed superficially and distally to form the nail plate. Different parts of the nail matrix form different sections of the nail plate. Generally, the dorsal aspect of the nail plate is formed from the proximal nail matrix, and the ventral nail plate is formed from the distal nail matrix. However, 80% of the nail plate is made from the proximal nail matrix. Therefore, a biopsy or surgery is the distal nail matrix will produce minimal damage to the nail plate. Nail plate. The nail plate is the hard keratinized structure made from compact onychocytes organized in a lamellar pattern. The dorsal surface of the nail plate is smooth with longitudinal ridges. Below the nail plate are the nail bed and part of the nail matrix. The nail bed and nail folds act as strong attachment points that help the free edge of the nail function as a tool without loosening the nail plate or causing pain. Nail bed. The nail bed is attached to the ventral surface of the nail plate and begins distal to the lunula and terminates at the hyponychium. The nail plate is attached to the nail bed through longitudinal epidermal ridges. These ridges on the ventral nail plate surface are complementary to the ridges on the nail bed, which function to increase the surface area of the nail plate's attachment to the underlying nail bed, thus augmenting the adhesion between these two surfaces. The nail bed does not produce a stratum corneum since the keratins necessary for the formation of this layer of the epidermis are not present. However, if onycholysis or loss of the nail plate occurs, the nail bed loses the longitudinal ridges and begins to express the keratins necessary to produce the stratium corneum. Below the nail bed is a thin layer of the collagenous dermis, which adheres to the periosteum of the underlying distal phalanx. The lack of subcutaneous fat can increase the risk of osteomyelitis of the distal phalanx in the setting of a nail infection. Hyponychium. The hyponychium is the area distal to the nail bed and beneath the free edge of the nail plate. Onychodermal band. The onychodermal band is part of the distal nail bed that is grossly represented in a contrasting color. It functions as the first barrier of protection on the free edge of the nail and is analogous to the cuticle. Changes in the color can correspond to different diseases or variations in vascular supply. Embryology. The nail starts to become visible around 8 weeks of gestation as a ridge on the digits. At 14 weeks, proximal fold has formed, and by 16 weeks, the basic nail unit can be recognized. At 5 months gestation, a well-formed nail plate completely covers the nail bed. Studies show the nail and underlying distal phalanx have an embryologic relationship which changes after birth and throughout life. Signaling molecules such as bone morphogenic proteins play a role in the formation of both nail and bone structures in the fingers. Congenital nail dystrophies have been associated with underlying bone defects, such as a bifid phalanx. Adults with psoriatic arthritis are more likely to have nail manifestations of their disease. Inflammation of the underlying joint and bone can disturb the proximal nail matrix, resulting in nail pitting or crumbling. Blood supply and lymphatics. The nail unit has a rich blood supply with many anastomotic channels to ensure proper blood flow, even if an occlusion occurs when the fingers are gripping an object. Both the radial and ulnar artery branch into superficial and deep palmar arches in the hand. The superficial palmar arch supplies most of the blood to the fingers by branching into the common digital arteries. Each common digital artery gives rise to 2 proper digital arteries which travel laterally on either side of each finger. This vessel then branches proximal to the distal interphalangeal joint into the dorsal digital arteries. The dorsal digital branch travels over the distal interphalangeal joint and becomes the superficial arcade. This tortuous vessel travels transversely about half a centimeter proximal to the cuticle and supplies the nail fold and nail matrix. The superficial arcade gives off multiple longitudinal subungual vessels that travel in parallel distally and anastomose with palmar digital arteries to form the proximal and distal subungual arcades, which supply the rest of the nail unit and nail bed. While there is a wide anatomic variation in the smaller vessels of the nail unit, all the vessels in the distal digits exhibit a notable tortuosity, which is thought to be a protective mechanism in case of occlusion. Venous drainage parallels arterial supply, except the vessels are superficial and the collecting veins are located in the lateral nail folds. A unique vascular structure, a part of the nail unit, are cavernous blood vessels known as glomus bodies. These end organ apparatuses are arteriovenous anastomosis that bypass a capillary bed. These structures are surrounded by cuboidal epithelial cells and pericytes that contract asynchronously with arterioles. In cold temperatures, arterioles feeding the glomus bodies will contract while the glomus bodies dilate. They are important for temperature regulation and preservation of blood flow in cold conditions.